Saddle up for a wild ride, VETgirl Pack. We're headed to the heart of Music City for VETgirl U this summer. So mark your calendar to join us for a rootin' tootin' good time, June 27th to 29th, 2025 at the Renaissance Nashville Hotel. We're bringing the heat with hot chicken, honky tonkin', and some seriously amazing CE.
In today's VETgirl Online Veterinary Continuing Education podcast, we're going to talk about the rare complications associated with nasogastric or nasoesophageal feeding tube misplacement in cats and dogs. We'll call these tubes NG or NE from now on. As the use of enteral feeding has become more widely accepted and common in small animal patients, veterinarians and veterinary technicians must be aware of the rare potential complications that can occur, some of which can be life-threatening. Now, placing feeding tubes is relatively easy. They don't require specialized equipment, they're inexpensive, and veterinary technicians can often place these with little to no sedation, well, depending on the personality of the cat. More on this later. In veterinary medicine, NG or NE tubes are often used to help aspirate stomach contents, such as residual gastric fluid secondary to ileus, facilitate easy administration of per-os or oral liquid medications, and aid in early enteral feeding in critically ill patients with underlying disease like parvovirus, pancreatitis, sepsis, and hepatic lipidosis. So in this podcast, we'll review a case report out of the Journal of American Animal Hospital Association by Lippert et al. Entitled Successful Medical Management of Bilateral Pneumothorax Due to Nasogastric Tube Misplacement in a Cat. In this case, a 7-year-old female spayed domestic shorthair cat presented for VETgirl's favorite emergency, poisoning. This cat had vomited plant material, a suspected orange lily, and was presented for treatment of lily toxicity. As the cat had already presented actively vomiting, emesis induction was not initiated. However, a nasogastric tube was placed to administer activated charcoal. Prior to this, the cat was tempted to eat charcoal mixed with food, but only ingested 6 mils. VETgirl tip, cats never eat enough charcoal, so I typically don't even offer it orally as compared to those poisoned Labrador retrievers. The cat was lightly sedated for NG tube placement, including low-dose butorphanol at 0.2 mg per kg IV and topical proparacaine solution applied to the nostrils. An additional 0.2 mg per kg of butorphanol was again administered after several unsuccessful attempts to pass the NG tube due to patient intolerance. According to the authors, this added butorphanol resulted in minimal improvement in sedation level. After the authors felt the NG tube was in place, and prior to the administration of activated charcoal, a lateral radiograph was taken to confirm placement of the NG tube, and actually revealed that the distal tip of the NG tube was erroneously in the retroperitoneal space. You should pull the original journal article to check out this radiograph, because if you looked at the radiograph very quickly, it could look like the tube was actually in the stomach. When in doubt, always take the time to slow down and confirm proper interpretation of tube checks to be safe. This is also why taking 2 views for placement radiographs can help us catch these. When it was noted that the NG tube was mispositioned, the NG tube was immediately removed while still in the radiology suite. Upon removal, the cat instantly developed severe tachypnea and respiratory distress, and was treated quickly with flow-by oxygen while a thoracic point-of-care ultrasound was performed. The point-of-care ultrasound revealed absence of a glide sign, confirming the diagnosis of pneumothorax. Following point-of-care ultrasound, the cat underwent a right-sided thoracocentesis, and authors note that negative pressure was not obtained. This means a continuous pneumothorax was present that could result in immediate death if not quickly addressed. A thoracostomy tube was placed via modified Seldinger technique in the right thorax under additional butorphanol sedation of 0.3 mg per kg IV, and chest radiographs showed appropriate placement of the right-sided thoracostomy tube, but also showed a severe pneumothorax present on the left side. Remember, even though cats are perhaps more commonly thought of as having their pleural air or fluid restricted to only one side of the chest, they absolutely can have communicating fenestrations, worsened by disease, that make a unilateral process, such as this cat's right-sided traumatic pneumothorax, become a bilateral problem. After discovering that this cat's pneumothorax was in fact bilateral, an additional thoracostomy tube was placed on the left side under even more sedation, including 0.2 mg/kg butorphanol and 0.2 mg/kg of midazolam IV. Follow-up, now our third set of chest radiographs, revealed that with functional bilateral chest tubes in place, the tension pneumothorax was now resolved on both sides. Over the next 2 days, the cat was treated with symptomatic supportive care, including fluid therapy, analgesics, including a fentanyl CRI and oral gabapentin for the chest tubes, oxygen therapy, ECG monitoring, and clinicopathologic monitoring. Thankfully, this cat did well and recovered. So the authors of this study go on to discuss the risks of sedation involved with NG or NE tube placement, from different options for sedation to their effects on suppressing cough. The authors discussed implementing protocols like using a laryngoscope to visualize the NG or NE tube in the oropharynx and ensure that the feeding tube isn't accidentally between the arytenoids and so placed into the lungs or pleural space, therefore minimizing the risk of injury, pneumothorax, or even bronchopleural fistulas. The medical management of bilateral pneumothorax necessitates a carefully orchestrated series of treatments, starting with the immediate stabilization of the patient's respiratory status. This includes rapid thoracocentesis to remove air from the pleural space, thus allowing the lungs to re-expand properly. Depending on severity of the pneumothorax, like continuous or tension pneumothorax, the swift placement of chest tubes in a well-prepared, controlled, aseptic manner is an imperative skill to know. With VETgirl being a boarded toxicologist, what is VETgirl's take on decontamination? VETgirl recommends not spending more than 20 to 30 minutes trying to decontaminate the veterinary patient. Personally, in cats, when I induce emesis, typically with dexmedetomidine, I take advantage of their sedated state and instead pass an orogastric tube with a 10 to 12 French red rubber catheter. Interestingly enough, it's actually quite easy to tube a cat. However, it requires some type of mouth gag device to prevent the cat from chewing through the orogastric tube. VETgirl uses a fancy syringe case as the mouth gag and passes the red rubber orogastric tube through the center of this plastic syringe case. Once placement of the orogastric tube is confirmed, to make sure that it's not in the trachea, you can then syringe in 60 ml of charcoal for the average cat. When in doubt, check the dose on your bottle of charcoal and confirm it with appropriate calculations. So, what do we take away from this VETgirl podcast? I'd say accidents happen, and being aware of the possible complications is just as important as diligence to learning to practicing these important veterinary procedures. Nasogastric tube misplacement leading to bilateral pneumothorax is a rare but life-threatening complication that can occur in veterinary medicine, and it requires rapid identification, prompt life-saving care such as thoracocentesis, and skilled intervention and monitoring for successful outcomes. And even though this complication is rare, veterinary professionals still must be aware of this potential complication.